A very good evening, students, all of you, and I hope you are reading the aminoglycosides and please put up any questions or any queries you have related to the topic. Woke up with a good news that one of the drugs, which is an antiviral drug, which is a nucleoside analog, remdesivir, has shown some promise in decreasing the mortality as well as the hospital stay in COVID patients. So at least there are some good news of some drugs which could be useful for COVID patients who are moderate to severely sick. So let us proceed with aminoglycoside students, and in the last session I discussed about the advantages of once daily regime over the multiple daily regime of aminoglycosides, and the basis of this regime is decided by two factors. One is the concentration dependent killing of aminoglycosides and the other is a long post antibiotic effect which these group of antimicrobials do have. So let us proceed today with the side effects of aminoglycosides and also the uses of these group of drugs. But before we go to them, let us have one MCQ which you would feel, I think, would be useful to you. Which one of the following statements about once daily dosing with aminoglycoside is false? It is convenient for outpatient therapy. Adjustment of dosage is less important in renal insufficiency. Less nursing time is required. It is often less toxic than the conventional dosing regimes, and underdosing is less of a problem. So what statement you feel is incorrect? Let us have the statements considered again. So for once daily dosing, is underdosing less of a problem? Yes, because once the patient comes, the nursing staff gets ready, they give the dose entirely in the morning, so there is no question of missing dose, so underdosing is less of a problem. So this is a correct statement. It is often less toxic than the conventional dosing regimes. No, we discussed in my previous session that conventional dosing regimes, the drug levels spend very less time below the level of threshold of toxicity. So it is better to give a single daily dose because that not only enhances efficacy but also decreases the toxicity. Of course, if you are to give it once a day, less nursing time is required. So that also becomes a true statement, and it is convenient for outpatient. Yes, because patient can have the drug administered once a day and then go home. So it can be useful for outpatient therapy. And the statement which is not correct is adjustment of dosage becomes more important in renal insufficiency, reason being that we are giving concentrations which are high, and if there is a renal insufficiency we might get accumulation of this drug, and that would backfire in the form of concentration of the drug in the endolymph as well as the perilymph of the inner ear. So this statement, students, is false, that adjustment of dosage is less important in renal insufficiency. It becomes rather more important in renal insufficiency, and I would tell you that renal impairment is one of the relative contraindications of not giving a once daily dosing. The other exceptions are pregnancy, and one of the other exceptions is that if you are giving it combined with the beta-lactam antibiotic for enterococcal endocarditis, then you would have to give it along as a with the cell wall active agent, and that has to be given multiple times a day. So whether you are giving once daily or multiple daily, whatever you choose, the golden rule is the dose must be adjusted for patients with creatinine clearances of below 800 to 100 ml per minute, and that signifies renal impairment, and the plasma concentrations must be monitored. So renal impairment is one of the factors which is going to be making us very cautious regarding the use of aminoglycosides, because aminoglycosides, I told you, are excreted unchanged in the urine, and if the kidney has not to flush them out, they roam about in the body in its active form. So that we need to be very, very careful. Of course, we have the Crockford-Gault formula, which was taught to you in general pharmacology as well as in pharmacokinetic calculations regarding how to adjust the dose of a nephrotoxic drug or a drug which you are expecting an accumulation in a setting of renal impairment based on the serum creatinine values of the patient. But that calculation may be a little bit tough, but there's a rough nomogram which is available. So either if the creatinine clearances is less than 100, you would be giving the dose every 24 hours. That is the standard regime, and you would be considering the percentage of maximum dose. So if it's 100 ml, which is normal, then you will be giving the full dose. Full dose of gentamicin and tobramycin is 5.5 milligram per kg. For amikacin, kanamycin and streptomycin, these doses are a little more because these drugs may be a little less potent, 15 milligram per kg. There's another drug, netilmicin. The dose is 6.5 milligrams per kilogram. So if you see here that if the creatinine clearances keep on falling, the percentage of maximum daily dose also keeps on falling. So 100, if there is 100% creatinine clearance, 75% of the maximum dose. If there is a 75 ml per minute as a creatinine clearance, 50% of the maximum dose if it is a 50 ml per minute. And if the creatinine clearances values are less than 25, then we might be giving little less of the dose also of the maximum dose expected, and we would also increase the frequency of dosing so that there is no question of drug accumulation. So in that case, the aminoglycosides will not only have less dose administered, as you can see here, as a percentage of maximum dose, but they would also be administered as spaced intervals. So instead of every 24 hours, you would be giving it every 48 hours. Now, with regard to its absorption, nothing much to say, nothing very great about the aminoglycosides as far as their absorption is concerned or their distribution is concerned. They are very, very polar substances, and they tend not to get absorbed in the intestine, and that is why they are never formulated as an oral preparation meant for systemic use. The reason is that they cannot be absorbed by the intestine. As far as the distribution is concerned, we always discussed in general pharmacology principles that more is the lipid-soluble drug, more is the volume of distribution. But here in case, because they are water-soluble drugs, the distribution definitely becomes limited to across the blood-brain barrier and to many other tissues, except that aminoglycosides, they distribute themselves in the endolymph and the perilymph of the inner ear, and that signifies it's one of the toxic effects for which they are known for, and they also accumulate in the renal cortex, and that could damage the kidneys also. But that is the reason why these drugs are also preferred in urinary tract infections, which are basically complicated upper urinary tract infections, which for these drugs become the drug of choice for uncomplicated urinary tract infection. I told you the most causative organism is E. coli, students. For uncomplicated simple infections, we would like to give fluoroquinolones or sulfa group of drugs. For more complicated infections, we would have to choose the aminoglycosides. So let us go further with their pharmacokinetic properties, and as I told you, they are not absorbed from the GIT. Yes, there is one indication of aminoglycoside use to be given orally, that is neomycin, which is the most nephrotoxic aminoglycoside, is given orally, and paromomycin, which is also one of the aminoglycosides we know, is given for intestinal amoebiasis. So they are meant actually for their local action in the intestine, because we know that neomycin will not be absorbed in the gut. It will be there in the gut. It is meant to suppress the gut flora out there, and same for paromomycin. It is meant to eradicate the amoeba and amoeba histolytica. So it is meant for intestinal amoebiasis. So it's not meant for systemic use. If you are giving the drug orally for systemic use, it will not have any effect, students. And please don't ever mention when we ask you in Viva what is the route of administration of aminoglycosides, please never say it is oral. Oral is reserved only for few indications. One is for intestinal amoebiasis and the other is for neomycin, which is used for bowel sterilization before surgery, or radiological examination, or to suppress the gut flora if the patient is having hepatic encephalopathy. I will deal with it a little while from now. The aminoglycosides, they don't cross many body cavities, they don't cross many body areas, but yes, if they are applied topically for long periods to large wounds, burns, cutaneous ulcers, or they are injected into the serosal surfaces, the pleural surfaces, or the peritoneal surfaces, they can get absorbed from there to such an extent that it can cause intoxication. So that could be one of the things which we should be watchful of. And as I told you, it doesn't cross the blood-brain barrier, or it doesn't reach the eye or most other secretions, but it loves to go into the endolymph and the perilymph of the inner ear. So how it goes there, how it can go so deep inside the ear is something which is still a medical marvel. We have not been able to understand, because aminoglycosides are so water soluble, if they can't cross the blood-brain barrier, how can they get into the endolymph and the perilymph of the inner ear? So that is what I was telling, that high concentrations are attained in two places. One is the renal cortex and the other is the inner ear, both the endolymph and the perilymph of the inner ear. These drugs can cross the placenta to such an extent that if you are giving high doses, then it can cross the placenta, reach the mother's plasma, and from there it can go to the fetal hearing apparatus and labyrinthine apparatus and try to have effect as far as fetal deafness is concerned. So that could be one of the concerns, and that is why aminoglycosides are usually avoided in pregnancy. And I told you the once daily regime, which provides large concentrations of aminoglycoside, at one point of time a pregnancy becomes an exception to it. Aminoglycosides are also given by the local route because they have problems as far as reaching their site of action is concerned. So they are given as an inhalation for management of patients with cystic fibrosis having pseudomonal pulmonary infections. These are the patients, they have land up with pseudomonal infections very commonly. So amikacin as an inhalation and tobramycin as an inhalation can be used. I want to repeat here that this drug does not cross the blood-brain barrier. So despite being very active for aerobic gram-negative bacilli, despite having good activity for H. influenzae, which can cause meningitis, this drug will not be useful, because even if you give the drug via the IM or the IM route, it cannot cross the blood-brain barrier. So two things are required if you want success in the antibiotic therapy or antimicrobial therapy. One is that the antimicrobial agent should have sensitivity for that organism. That is number one, most important. Second thing is that the antimicrobial should be able to reach the site of infection. So if any of the one or two fails, then you cannot have a success in antimicrobial therapy. But yes, if you still want to give aminoglycosides for their CNS infections, you have to give it by the intrathecal route. You can give it, the gentamicin has already been given intraventricularly. That's a very sophisticated way of injection, very not so safe also. So these drugs are usually not preferred for gram-negative meningitis. We rather prefer the cephalosporins for the same, because the third generation cephalosporins like ceftriaxone, they have a good penetrability across the blood-brain barrier. And since these drugs are usually very polar or highly polar, they are not metabolized in the liver. The liver doesn't have to exert much when you are being given aminoglycosides, but yes, the renal system does exert well. It has to be optimum to flush out the drug. Otherwise, there is going to be accumulation, and if there is a accumulation of this active drug, then there will be no gradient for back diffusion which will be created from the endolymph or the perilymph back into the plasma, as we discussed in the previous session, which is also very mandatory, because if you want to have the drug out of this inner ear, you have to have the plasma concentrations below the threshold for toxicity. So that is one thing, the vicious cycle. If there's renal impairment, then we might expect involvement of the inner ear also. So coming to the antimicrobial spectrum, students, I told you it's a narrow spectrum agent. If it's a narrow spectrum agent, that means it is going to provide targeted bacterial killing. These drugs are bactericidal in nature, knowing into its mechanism of action that they can freeze the initiation complexes. They form aberrant proteins, they lead to abnormal anticodon recognition. They inhibit the translation down the 5'3' line of the ribosome. So they are having a narrow spectrum, but bactericidal action. antimicrobial spectrum is narrow. So if it is narrow, it means that these drugs are very less associated with the problem which is associated with broad spectrum antibiotic, is the occurrence of super infection. So with aminoglycosides, we'll never have a super infection as we will have with other drugs, broad spectrum agents like fluoroquinolones or sulfamethoxazole or cotrimoxazole or third generation cephalosporins for that matter. So that is its spectrum, and it is active against few gram-positive bacteria, especially the enterococci and the streptococcus viridans. They are active against these 2 gram-positive bacteria. They are not active against anaerobic bacteria, because anaerobic bacteria will lack the transport facility which will bring the aminoglycoside inside the cell, and then it will be affecting the protein synthesis. They are not effective against fungi, viruses or parasites. Of course, as they say, the Antiamoeba histolytica, paromomycin is an aminoglycoside which might be active against the protozoa, and they do not have activity against rickettsia or chlamydia, and they also do not have any activity against the gram-negative bacilli, Salmonella typhi. They are not useful for typhoid fever. So that is about the aminoglycosides spectrum. I also told you that they are entirely filtered by the glomerular filtration, and they are excreted unchanged within 24 hours. And if renal function is impaired, you can expect accumulation of the drug. And if you expect accumulation of the drug, then there is going to be a vicious cycle, because if drug levels in the plasma don't fall, then the back diffusion of the drug from the inner ear, the endolymph and the perilymph of the inner ear, is not going to happen. So the drug is going to get large in the inner ear, and you know that they combine with the hair cells of the cochlea. They are leading to an irreversible type of deafness. So you have to decrease the maintenance dose if there is an impaired renal function. We just had a look at that nomogram. Either we decrease the maintenance dose, or we decrease the prolong the dosing interval, or go for both depending upon the requirement of the patient and his renal function. Now students, we come to the adverse effects of aminoglycosides, and sometimes you are asked in the examination, what are the shared side effects or shared toxicities of aminoglycosides? They are called the class effects, students. The class effects you have to remember, and one of the class effects, which is toxicity which is shared by all aminoglycosides, is ototoxicity. Now this ototoxicity, students, is irreversible, and it is of course dose and duration based. The more you give the drug, the more dose you give the drug, it is directly linked to it. But yes, there is a crux here, because some studies have shown that some people, they start getting deaf even with 2 or 3 doses of aminoglycosides. So that has been put that there is an abnormal mutation in their mitochondrial ribosome, and that mutated ribosome, resembles the bacterial ribosome more, and that is the reason for ototoxicity. So these are the adverse effects of the aminoglycosides. They cause progressive destruction of the sensory cells in the cochlea and the vestibular organ of the ear, and they accumulate in the perilymph and the endolymph of the inner ear, and this toxicity, students, is irreversible. So we have to be very careful. So they always say prevention is better than cure. So why not to prevent it by routine monitoring of aminoglycoside drug levels? Why not prevent it by ensuring that the renal functions are normal? And why not prevent it by giving a lower maintenance dose in a setting where you expect renal impairment? As far as there is some association of preferential toxicity also, that streptomycin and gentamicin, they have more vestibulotoxic function, whereas neomycin and amikacin, they mostly affect the hearing. Neomycin is also one of the most toxic aminoglycosides. It is most nephrotoxic, and yes, it does have an influence on the hearing part. And streptomycin and gentamicin, they have more effect on the balanced vestibular function part. Gentamicin, I would like to tell you, students, is also one of the most nephrotoxic aminoglycoside, and streptomycin, students, which is a drug which was given earlier for tuberculosis, is the least nephrotoxic aminoglycosides. So among the toxicities also, aminoglycosides show some preference as far as the toxicity is concerned. This ototoxicity by aminoglycosides is, of course, can be subjected to unwanted drug-drug interactions. If you combine aminoglycosides with loop diuretics in the form of furosemide or ethacrylinic acid, the loop diuretics themselves are ototoxic. So if you are also giving aminoglycosides along with them, you can expect more ototoxicity in the individual. And also one ototoxicity concern I would like to raise is that when we are giving these drugs for management of enterococcal endocarditis, where we can combine the glycopeptide antibiotic, which is a cell wall active agent, vancomycin. If aminoglycosides like gentamicin are combined with vancomycin for patient benefit, vancomycin also is an ototoxic agent. So both the ototoxicities can add up, and that would cause the unwanted drug-drug interaction. So while prescribing, we have to be careful that patient is not on any loop diuretic for his hypertension or his heart failure, and then only go along with aminoglycoside. And if the aminoglycosides are really indicated, then you have to be watchful of the ototoxicity. And remember, the body always gives warnings. It's not that the person has, you have to just recognize those warnings, because initial appearance of ototoxicity is ringing in the ears. So if the drug is stopped at that point of time, then the ototoxicity is reversible. But yes, if you just keep on ignoring it and just prolonging the things, then they become irreversible. As I was telling you, the contribution of genetic susceptibility to the overall incidence of aminoglycoside-induced ototoxicity is still unclear, but surveys of subjects of European origin put the prevalence of one of these mutations at 1 in 500. So that's not so rare, and that's not so common also. So let us see what is the susceptibility. There is a particular mutation they have identified. There is an increased susceptibility to hearing loss caused by aminoglycoside antibiotics is in some families inherited quite differently, namely exclusively through the mother to all her children. So that is what this is a pattern they observed. This is the pattern expected of a mitochondrial gene, and indeed the most common predisposing mutation is M.155A, a mitochondrial gene mutation. This mutation accounts for 30 to 60% of aminoglycoside ototoxicity in China, where aminoglycoside use is common. China is in the news these days, and the outbreak of COVID also began in China, and ototoxicity with the aminoglycosides is also seen in Chinese population. And I would like to tell you the reason. The aminoglycosides work by binding to bacterial ribosomes, which share properties with human mitochondrial ribosomes. They might not share properties with the other type of ribosomes. They are 60 and 40. Bacterial ribosome is 30 and 50. But yes, the mitochondrial ribosome is very much similar to the bacterial ribosome. So that is why I would like to take back my words that aminoglycosides are exerting selective toxicity, because mitochondria are believed to have evolved from the symbiotic bacteria, and this mutation in the mitochondrial gene, or the mitochondrial ribosome, or the mitochondrial gene, makes that mitochondrial ribosome very close in structure to the bacterial ribosome. So if the aminoglycosides are affecting bacterial ribosomal synthesis, they also are going to inhibit the actions of the mitochondrial protein synthesis, students. This mutation, which is M.155A, makes mitochondrial ribosomes even more similar to their bacterial counterparts, increasing the affinity of the drug, which remains bound to the ribosomes in the hair cells in the ear for several months following a single dose. A single dose, students, is just a question of single dose can cause deafness. So good part is we don't have such screening in our country available at this point of time, but in future we might have. This is one of the pharmacogenetic variations which is seen in the population. We have many examples which is given in the textbook, but yes, you can add this example that a mitochondrial gene mutation might be responsible for more ototoxicity, which is seen in aminoglycosides in some individuals rather in 1 or 2 doses as compared to the others. There are other postulates also that this permanent dysfunction is dose-related and duration-related of the aminoglycoside. And there is a formation of an iron aminoglycoside complex which is postulated to potentiate reactive oxygen species, and that would cause degeneration in the cochlea. The cochlear toxicity manifests as tinnitus and auditory impairment after a few days. So beginning our features are tinnitus, as happens with all types of deafness. There is high frequency sound sounds are not heard first, followed by low frequency sounds, and that is about the cochlear toxicity. As far as the vestibular toxicity is concerned, it is a chronic type of toxicity which is characterized into various stages. It begins with a headache which lasts for 3-4 days, followed by an acute phase and then a chronic phase. But you know, we have recognized the association of aminoglycoside with such type of dangerous toxicities. Now, these type of pictures with advanced vestibular cochlear damage of aminoglycosides are rare, but they have been described in the past, and students, you should know it if you are asked a short note on shared toxicities of aminoglycosides. As I told you, it begins with a headache lasting 1 or 2 days, and then it proceeds to nausea and vomiting, which is characterized as an acute state. And in this stage, we might have nystagmus. Patient might have vertigo in the upright position, but not while sitting, inability to perceive termination of movement, and difficulty in sitting or standing without visual clues. That means you will have difficulty in standing if his eyes are closed. So that is what is the acute phase, followed by a chronic phase of 2 months, which is asymptomatic when supine. Changing position, the ataxia becomes the main feature, followed by the compensatory stage, which is 12 to 18 months, where symptoms will appear only when the eyes are closed. Otherwise, the patient is able to carry on his work. But yes, this is an irreversible thing to happen and not a good thing to happen. As far as the third adverse effect of the aminoglycosides go, it leads to nephrotoxicity. This nephrotoxicity is reversible because the proximal tubular cells of the kidney have the capacity to regenerate. So, but yes, if there is nephrotoxicity, it could lead to a vicious cycle of autotoxicity, as I explained to you, and that is why we have to be watchful of this nephrotoxicity. The aminoglycosides love to get concentrated in the renal cortex, and that implies its use in dangerous or complicated urinary tract infections, and that implies its side effects also. So as far as nephrotoxicity is concerned, neomycin and gentamicin, students, are most nephrotoxic. Streptomycin is least nephrotoxic. So there is damage to the renal tubules, reversible if users stop, is likely to be seen in patients with pre-existing renal disease or who are already on other nephrotoxic agents like amphotericin B or vancomycin or beta-lactam antibiotics. They are also nephrotoxic in nature, and then that will add up. As autotoxicity adds up, similarly nephrotoxicity also is going to add up. So neomycin, I would like to repeat here again, students, is concentrated to a greatest degree, which is highly nephrotoxic. Streptomycin is not concentrated in the renal cortex, and it causes more of vestibular toxicity, as we suggested, not nephrotoxicity. It is least nephrotoxic, and the vicious cycle I told you of leading to autotoxicity. Hence, aminoglycosides are one such drugs where plasma monitoring, concentrations, plasma monitoring is important. Now, adverse effects, the third adverse effect is not seen with therapeutic doses. Always remember the students, is not seen with therapeutic doses. It is seen only with the supratherapeutic or higher doses. When you inject aminoglycosides in serosal cavities or pleural spaces, then it gets absorbed from the serosal surfaces, and that is the time it presents with the neuromuscular blockade. This neuromuscular blockade can be additive with the patients who are already having myasthenia, because in myasthenia also the acetylcholine antibodies receptors are not so much, because they are destroyed by the autoantibodies present in the person's body. So, and this drug, you know, aminoglycoside is a prejunctional toxin that is going to inhibit the release of acetylcholine from the presynaptic terminal, the same way as botulinum toxin works. So it's going to bring about the same effect, and that is going to cause neuromuscular blockade. Of course, this is irreversible. We can treat this neuromuscular blockade by giving calcium, because if you give calcium from outside intravenously, then it is going to trigger the release of the neurotransmitter into the junctional cleft, and that is going to bring about some relief from this particular condition. It is a rare but serious side effect, and paralysis can be caused by neuromuscular blockade, and the reason is that they inhibit the prejunctional release of acetylcholine while also reducing the postsynaptic sensitivity to the transmitter. So that is one problem. Patients with myasthenia are more susceptible, and IV calcium salt for this condition is the preferred treatment. So let us revise the shared toxicity, students. It can cause autotoxicity in the form of cochlear toxicity and vestibular toxicity. It can cause nephrotoxicity by accumulation in the renal cortex, it can cause paralysis and it can cause skin rash. Of course, the incidence of skin rash is not so much with the aminoglycoside as it with the sulfa group of drugs or as it is the penicillin, but yes, there is a risk is there. Anaphylaxis is rare with aminoglycosides, and dangerous allergic reactions are also rare with aminoglycosides, but autotoxicity and nephrotoxicity, students, are very common with aminoglycosides. As far as the individual side effects are concerned, streptomycin has its own list of side effects. It can cause damage to the eyes, it can cause optic neuritis, which can present as blind spots, and it can also cause peripheral neuritis. Paresthesias can happen, especially in the perioral areas, that is the area around the face or the mouth or in the hands, and it usually appears within 30 to 60 minutes after injection, and it might be reversible to some extent. Hypersensitivity, of course, is not so much observed. It has little allergic potential and no association of aminoglycoside, students, because it's a narrow spectrum antibiotic. It has no association with pseudomembranous colitis, which is a toxicity, or which is a super infection which we see when we give the broad spectrum antibiotics. So students, we stop here for a while, and I will definitely come to you very soon with the discussion of individual aminoglycosides. So one good news we got up with, that is the remdesivir showing some promise for COVID, but another bad news that we lost two very prolific actors, Mr. Rishi Kapoor and Mr. Irfan Khan. May their soul rest in peace. And of course, we'll be missing their movies, we'll be missing their emotional expression a lot. And yes, that is the sad news for today. So students, continue to read, and I'll be getting you the things very sooner, and wait for the next part. Thank you so much, students.